what's up? Today we're going to talk about distribution. So what's distribution? Let's write the topic here. So what is distribution? Distribution is the process of distribution where allotment of the drugs from the systemic circulation to different parts of the body, different organs and the tissues, right? So basically, if this is your systemic circulation, then this happens to be your kidney, this is your brain, right? And this is your heart. So the drug is already present in your system, right? If this is a drug. Now the drug has to get loaded to different parts of the body, right? So if now these are the vessels going to different organs. So the drug is present in the systemic circulation. Now it has to get distributed to different parts of the body, and this whole process of the drug getting into the organs and the tissues from the systemic circulation, that's called distribution. Now, so what happens when your drug first gets into the plasma? Suppose this is your blood vessel, all right? So what happens when you inject a drug? When you inject a drug into this blood vessel, first the drug, suppose this is the drug. When the drug gets into the plasma, it first binds with the plasma protein. Plasma protein, right? So now it becomes plasma protein and drug complex. Right, so let's make it. Let's show you in figure. So if this is your drug, and this is your plasma protein. Suppose the plasma protein has a binding site, right? Now, if we cover this in figure, what it looks like is this is the binding site of the plasma protein. Now the drug comes and binds here. So the plasma protein and the drug, when they combine, they make plasma protein and drug complex, and the complex looks like this, right? Now, so there are many drug molecules, right? There are many plasma proteins, and the plasma proteins bind to the drug. So here's the plasma protein and the drug molecule, and let's make the blood vessels illumine a bit more wider. So this is plasma protein and the drug complex. Now, what if this drug, now let's put it this way. So this drug and plasma proteins are combined together, right? The drug is happy, the plasma protein is happy, there's no any other drug to compete with this drug. Now what happens if some other drug, for example, a drug named S, comes into this environment? Now, what it does is the drug S will compete with this drug. Now it will replace it. It will displace the drug. Now the drug will come out from that protein. Now, the S drug will go and sit in the plasma protein. The same way, another S drug will sit in here. Now, the drug has been displaced. Now, let's make it red. You see here? Now, the drug was attached to the plasma protein previously, right? So, but it displaced the drug from the plasma protein. Now, the S drug came, and the drug replaced the D from the plasma protein, right? It's because S drug came, S drug came and replaced, now S drug came, replaced, and this happened, right? So, what I'm telling you is, this drug, when this drug replaces the drug D, now the drug is free in the plasma. And one thing we should keep in mind is the drug, this is free form of the drug. Free form of the drug. It's unbound, right? And it's very active form. The drug, when it's combined with the plasma proteins, they are inactive form. Inactive form, right? So when the drug is combined with the plasma proteins, these are inactive form. And when they are not combined with the plasma protein, they are active form, or they are free form, right? They get diffused into the tissues and they can cross by membranes. So they are reactive, or they are active. But these plasma protein bound drugs cannot easily diffuse through the drug, so by membranes. That's why they are inactive one. Right, so suppose the drug that has been displaced, suppose this drug is a drug that is very dangerous, that is very narrow therapeutic range. So what happens if the drug is replaced and the concentration of the drug, which has a narrow therapeutic index, is increased in the plasma? Now what happens is it will show its negative effect. It will show its side effects, right? So this drug, which was very, very dangerous and which has very, very narrow therapeutic range, this drug is now going to show its negative side effects in the body. So what if this drug is warfarin? And what if this drug that just replaced the warfarin is sulfonamide? Right? So sulfonamide is also a highly proton-bound drug, and this warfarin is also a highly proton-bound drug. But when we give sulfonamide drug in the patient who was on warfarin, then the sulfonamide will replace the drug warfarin from the plasma proteins. Now the warfarin, which was bound to the plasma proteins, is out and free. Now this free warfarin will show its side effects. So the patient will present with a chief complaint of bleeding or bruising, easy bruising. So this is a dangerous drug interaction, right? So there's another example which is very clinically important, and that's let's rub it. What if this drug, in place of this D, what if it was unconjugated bilirubin in case of neonate? You know what? Neonate hyperbilirubinemia, that's most of the time, if that's physiologic, that's not that much thing to worry about. But if the bilirubin is so much that if it crosses 25, greater than 25 milligram per deciliter in the blood, then it can cause chronic tears. Chronic tears is basically the CNS manifestation of the hyperbilirubinemia, right? And if there's hyperbilirubinemia, that may cause bilirubin encephalopathy, right? So what if the unconjugated bilirubin was actually bound to the plasma protein, previously, right? Now we give the same neonate who had hyperbilirubinemia and who had that unconjugated bilirubin attached to the plasma protein. Now we give that neonate sulfonamide. Now what happens? The sulfonamide will displace the drug from the plasma protein. See, now the unconjugated bilirubin is out and free. It's out and free, right? It's out and free. You see? Now this unconjugated bilirubin is out and free. The plasma concentration of the free unconjugated bilirubin is very much high in the blood. Now this will go into the brain and it causes chronic tears and bilirubin encephalopathy. So there are two important drug reactions, that is sulfonamide and the unconjugated hyperbilirubinemia in the child, the neonate. And the next thing very important we need to talk about is, we already discussed, that's warfarin and sulfonamides. So sulfonamides are given in infections. Basically, these are the antibiotics, right? So when we give antibiotic, that sulfonamide groups antibiotic with the warfarin, it will displace, it will compete with the warfarin to bind with the binding site in the plasma proteins, and the warfarin will come out and it will show its negative effect. And same happens with the unconjugated bilirubin. So this was what I wanted to discuss in this section. Now let's get into the spatial barrier for distribution. So what are the spatial barrier in distribution? The first one is going to be your placental barrier. The next one is going to be your blood-brain barrier. And what placental barrier? That lets only low molecular weight drugs to pass through it, and this blood-brain barrier is basically allows the lipid soluble drugs to get traversed through it, right? So what if you wanted to give a drug to pregnant women? So how can you make a drug safer in pregnancy? First of all, if you have high molecular weight drug, then that obviously has larger molecular size, so it cannot pass the placenta. And if you have water-soluble drug, that gives plus point to you, because water-soluble drug cannot pass through the lipid bilayer membrane, right? Because water-soluble basically means the compound is polar and it cannot dissolve in the lipid, and it cannot pass through the membrane. And what if you can also make a drug that is highly protein bound, right? But if you have all these three characteristics in the drug, then that is very much safer in the pregnancy. But one caveat there is you cannot make a drug water soluble and plasma protein bound at the same time, because plasma protein bound drugs are the drugs that basically bind to the lipid. They're soluble to the lipid, and that means a drug cannot be lipid soluble and water soluble at the same time. So either you can choose to make a drug with high molecular weight and water soluble, or you can choose to make a drug that's high in molecular weight and that's protein bound. So if you combine these two things, then you can make a safer drug for pregnancy. So this is basically a placental barrier. Now, blood-brain barrier. This blood-brain barrier, as I already told, the brain allows only the lipid-soluble drug to enter through it, and or the drug, if the drug can be transported by the active transport or facilitated diffusion, and that kind of drug also can cross the membrane, this blood-brain barrier, right? And the next thing is, and if there is the drug has low molecular weight, it can also enter through the blood-brain barrier, right? Now, one very high yield point, there is lithium. Lithium is probably the most smallest molecule, right? It's the most smallest or lowest molecular weight drug that can traverse through the blood-brain barrier. Even if it's ionized, it's polar. Even if it's not lipid soluble, it can go through the blood-brain barrier because it's very much low in molecular weight, or let's say it's very small in size. That's why, right? Let's not say low in molecular weight. Let's say it's very smaller in size. Now there's another example, or exception, whatever we call this ethanol. This ethanol, it's alcohols are basically they are organic solvents, but since alcohol has hydroxyl group on them, the alcohols are usually soluble in water, right? But among them, ethanol is even much more soluble because of its smaller size and exposed hydroxyl group in it. So ethanol, although it's water soluble, it can get through the blood-brain barrier. Why? Because of its small molecular weight. So this much in the distribution section. We'll cover the apparent volume of distribution in the next video. So this much in this video. Thank you. See you.